Hello everyone, this is Dr. Bankim and today I am making this video for the Facebook page Nuclear Medicine in Northeast India, that is NMINE India. This is just a simple step to popularize or uplift nuclear medicine in Northeast India, where this particular specialty is far lacking behind as compared to the rest of the country or to the rest of the world. And most of the people do not know much about nuclear medicine as far as Northeast region is concerned, and it is specifically true in the case of this particular topic, that is myocardial perfusion imaging in cardiology practice. So I'm just trying to make a brief highlight so as to make the people aware of the usefulness of this um, novel technology. And okay, myocardial perfusion imaging is most commonly known as thallium scan, but I'm going to stick to the term MPI in the rest of my discussion as much as possible. I will be discussing myocardial perfusion imaging or MPI under three main headings. Number one, what is an MPI or what is a myocardial perfusion imaging? Number two, what does an MPI image look like, or how does an MPI image look like? And lastly, I will come to the clinical value of myocardial perfusion imaging. Myocardial perfusion imaging is a kind of stress test, like the usual exercise stress test, in which patient is fitted with ECG leads, and we see for any or we look for any changes in the ECG during exercise. However, in the case of myocardial perfusion imaging, over and above the ECG monitoring, we inject a tracer or a dye in layman term to the patient when the patient is having a peak exercise, and these tracers localize into the myocardium. These tracers are radioactive and they release photons, and these photons are acquired by a gamma camera to form the myocardial perfusion imaging stress image. That is, the images formed when the imaging is done just after the exercise is called the stress image. Now, in the second part, patient is patient is allowed to take rest, and we may or may not inject the same tracer to the patient depending on the type of tracer that I'm going to explain later. And the same gamma camera is used to acquire the images again, but this time we do not stress the patient. This is the resting image. So the images acquired when the patient is at rest forms the rest images, and these two sets of images, stress images and the rest images, are displayed side by side or alternatively, and we look for any differences or any changes between the stress and the rest images. This is in simple term how an MPI image or how an MPI imaging protocol works. Before I go into the details of MPI, let me talk about the indications first. These indications are, are taken from the American Society of Nuclear Cardiology guidelines published in 2009. In fact, these indications were a derivation of the appropriate use criteria, which was a consensus criteria from a number of societies and associations published in the Journal of the American College of Cardiology in 2009. So the first indication is detection of obstructive coronary artery disease in patients with intermediate pre-test probability of coronary artery disease, or in those patients with high risk factors for coronary artery disease, such as diabetes mellitus or peripheral or cerebral vascular disease. Number 2, risk stratification of post-MI patients before discharge. With submaximal exercise, we can do it um, at 4 to 6 days. However, with vasodilators like adenosine, we can do it as early as 2 days. Number 3, risk stratification of patients with chronic stable coronary artery disease, so as to place the patients into a group, low risk category group, that can be managed conservatively with medications, or into a high risk category group who needs or a more invasive form of treatment in the form of revascularization, such as PCI for kidney intervention, or CABG, coronary artery bypass grafting. Number 4, risk stratification of ACS patients, acute coronary syndrome patients, in whom there is no active ischemia or heart failure. One similar condition I would like to mention here is the case which we usually encounter in the emergency room. That is a patient of chest pain coming to the emergency room. So it is a protocol for us to perform an ECG and cardiac enzymes in such patients. Yeah, that is part of the normal protocol. And I just want to mention that we also can do MPI scan in such patients. The only difference is that we do not stress the patient, since the patient is already having chest pain and signs and symptoms of compromise in the myocardial perfusion. So what do we do? When the patient is having chest pain, we inject a tracer, and after the symptoms are controlled, we do the imaging with a gamma camera, say around 4 to 5 hours later, and that will result in myocardial perfusion imaging picture or images, and those images forms the baseline scan, and from the baseline scan we can diagnose whether the patient's chest pain was actually due to coronary artery disease or not. Okay, let's go one step ahead. Let's assume that the patient underwent some thrombolysis. Now, after thrombolysis, we can again inject the tracer to the patient and do the imaging again. So we get the post thrombolysis image, and these two sets of images, the previous image, that is the image when the patient was having chest pain, and the later image, that is the post thrombolysis image, these two sets of images can be compared, and we can assess whether the thrombolysis was actually working or not. And lastly, when the patient has fully recovered, say around after a few weeks or months, then the patient can undergo the classic stress rest myocardial perfusion imaging protocol, and this is to assess whether there is any residual ischemia or not. Number 5, risk stratification before non-cardiac surgery in patients with non-coronary artery disease, or in those with high risk factors for coronary artery disease. Last but not the least, MPI is very useful in the follow-up of patients who have undergone treatment, such as PCI or CABG, and also to assess the therapeutic efficacy of interventions like medications or revascularization. In order to understand and interpret an MPI scan, we need to have a thorough idea about the coronary vasculature. We have to know the areas supplied by the LED. We have to know the areas supplied by the LCX, or the areas supplied by the right coronary artery, and also the anomalies, uh, common anomalies like dominance, which might be left or right, and the presence of multiple diagonals, ramus intermedius, or obtuse marginals, and the types of LED. Uh, Diagonal is a branch of LED, but it might be multiple in some people, and ramus intermedius is seen in 15% of the population. Normally, the left main coronary artery bifurcates into LCX and LED. However, in 15% of the population, instead of bifurcating, it trifurcates into LED, LCX, and the mid portion, ramus intermedius. Obtuse marginals are branches from the LCX and supply the lateral wall. Actually, the diagonals usually supply the anterolateral wall. But ramus intermedius can behave both as diagonals, thereby supplying the areas supplied by the diagonals, or it might also behave as obtuse marginals, thereby supplying the lateral wall that is supplied by the marginals. There are 4 types of LEDs. In type 1, LED does not supply the apex. The RCA supplies the apex instead. In type 2, both LED and RCA supply the apex. In type 3, only the LED supplies the apex. In type 4, LED supplies the apex, and it also winds around or wraps around the apex and supplies a portion of the inferior wall too. Now we come to the contrast agents or dyes used for an MPI study. We call them radiopharmaceuticals because they are radioactive. There are a number of radiopharmaceutical agents for MPI, but the most important tracers are thallium, systematic technetium, and the tetraphosphine technetium. Thallium was introduced in the 1970s, while the latter two were introduced in the 1990s. And these latter two technetium agents have better imaging quality or properties as compared to thallium. But even though thallium is a very old tracer, it is still very useful for assessing the myocardial viability, because the technetium agents usually underestimate myocardial viability. Now, coming to the mechanism, how do these tracers localize into the myocardium? For thallium is a potassium analog, and it is taken off by the myocardium with the help of sodium potassium ATPase pump. In the case of technetium agents like systematic or tetraphosphine, these are lipophilic cations, so they diffuse through the sarcolemma of the myocardium, and then they localize into the mitochondria of the myocardium due to the difference in the electric potential. Why do we need myocardial perfusion imaging? As we can see from this scatter plot, the degree of stenosis does not have any relationship with the fractional flow reserve, which is a physiologic parameter and which has direct relationship with the myocardial blood flow and the perfusion. It is defined as pressure distal to a stenosis divided by the pressure proximal to the stenosis. The higher the value of fractional flow reserve, the better is the coronary blood flow and coronary perfusion. And accepted cutoff level is 0.80 or 0.75, or it ranges from 0.75 to 0.80. And the higher the fractional flow reserve, the better the coronary blood flow. So stenosis, which is an anatomic parameter, does not always equal physiology, that is the fractional flow reserve. That's where we require a physiologic test, because physiology impacts upon the patient outcome when we treat based on the functional parameters. Now we have a CT angio picture here, conventional angio here, and a fractional flow reserve measurement here. There seems to be a stenosis in the LAD, but it looks like it is not very much stenotic. So with quantitative CTO as well as conventional angio, the stenosis was found to be less than 50%, which is not clinically significant. A clinically significant stenosis is more than 70% diameter stenosis. So in this patient with less than 50% stenosis, when the fractional flow reserve was measured, it was 0.71, which is significant. So what does this mean? It means that an angiographic finding which looks insignificant clinically is in fact significant functionally. Again, emphasizing the fact that anatomy does not always equal physiology. Now we have another patient. There is a stenosis in the right coronary artery here, both in the CT angio and the conventional angio. These are the artifacts. And actually the stenosis was found to be more than 50%, which indicates that further evaluation is required. 50% to 70% diameter stenosis can be considered intermediate category. However, when the fractional flow reserve was calculated, it was found to be 0.78, which is not considered clinically significant. So, an angiographic finding which looks like clinically significant might, in fact, not be clinically significant from the functional point of view. This is an extract from the FAM trial. FAM trial is fractional flow reserve. FAM trial is fractional flow reserve versus angiography in multi-vessel evaluation trial. Patients were divided into two groups in this randomized trial. In one group or in one arm, percutaneous intervention, that is PCI, was performed in those patients who had fractional flow reserve less than 80%. That means PCI was guided by fractional flow reserve. In the other arm, PCI was performed based on the angiography findings only. Those patients who had more than 50% stenosis underwent PCI. As we can see from this survival curve, the survival in the fractional flow reserve group is much better than the survival in the angiography guided PCI group. So physiology, that is fractional flow reserve and not stenosis, predicts treatment outcome. All this leads us to a test which is physiologic and non-invasive, that is called myocardial perfusion imaging. The two donut signs on the right side of the slide, these are the left ventricle when the left ventricle is cut along the short axis in the cross section. This plot is the myocardial blood flow versus the degree of stenosis. Blue curve is the resting myocardial blood flow. Red plot is the myocardial blood flow under stress or exercise. Now let's assume 70% stenosis. In the resting state, the blood flow across the normal vasculature, non-stenotic arteries, as well as the blood flow across the stenotic arteries might be equivalent. So when we inject the radiotracer or thallium, the delivery of thallium by the stenotic artery might be equal to that of the normal arteries, and hence the myocardium will get equivalent amounts of thallium, thereby showing homogeneous radiotracer uptake without any visible defect. Now, when the patient undergoes some stress, there is increased blood flow. In the normal arteries, the increased blood flow will deliver increased amount of thallium. However, the fractional flow reserve across the stenotic lesion is compromised, and hence the blood flow uh, uh, across the stenotic artery is compromised or reduced as compared to the increased blood flow in the normal arteries under stress. It is shown by the smaller arrow here. So when we inject a tracer or thallium, there will be lesser delivery of thallium by the stenotic artery and hence lesser uptake, and it will appear as cold defect or some photophonic defect we call it. And the normal myocardium supplied by the normal artery will appear increased uptake, and we can see the heterogeneity in the uptake. This is how, in simple explanation, a myocardial perfusion imaging works. As I have mentioned earlier, myocardial perfusion imaging is a kind of nuclear stress test. The purpose of the stress is to increase myocardial blood flow, and there are a variety of modalities to increase myocardial blood flow. The most physiologic method is exercise, which is done with the standard Bruce protocol. Dobutamine also can mimic exercise as it increases the myocardial work. Amongst the vasodilators, adenosine is very important, and under adenosine, the coronary arteries dilate, and there is increased blood flow. However, the capacity of the coronary arteries to increase blood flow is limited in the presence of significant or functionally significant stenosis. In one way, it can be thought of as a kind of coronary steal phenomenon. However, a true coronary steal phenomenon with a true ischemia is very, very rare. And other vasodilators like diphenylamine and regadenoson also works on the same principle. Regadenoson is the latest of these agents. Now this slide shows the exercise stress MPI protocol. The upper portion is thallium and the lower portion is for technetium agents. I will not go into the details, but in brief, under stress at peak exercise, thallium is injected, and imaging is done within 10 to 15 minutes, and later on, around 3 to 4 hours later, we can do the rest imaging again. Thallium might or might not be injected again for the rest imaging, depending on the clinical scenario or condition, or depending on the technical feasibility. Now for the technetium agents, we need 2 injections, one during the stress imaging and the other during the rest imaging. Now we have pharmacological stress, the most important agent being adenosine. Adenosine is given at a dose of 140 micrograms per kg per minute for 6 minutes, and the tracer is injected midway, that is at 3 minutes, and the imaging is done 3 minutes after the completion of adenosine infusion. I will not go into the details about the other agents. The technique of myocardial perfusion imaging is called SPECT, single photon emission computed tomography. MPI can also be done with PET, positron emission tomography. However, the contrast agents or dyes or tracers are different, and as PET is not widely available, SPECT remains the most commonly performed standard modality of MPI. It is done with a gamma camera, and the images are displayed in various formats like multiple slices and 3D rendering images or 3D formats, and ventricular volumes or time activity curves we call it. One important term I would like to mention here is the gated SPECT. Gating by definition means the synchronization of electrical events, that is ECG, with mechanical events, that is myocardial contraction. So when these two events are synchronized, we can actually see the heart pumping in a cinematographic or movie format. And with the heart pumping dynamically, as we see, we can assess any abnormality in the myocardial contraction, such as any lag in the contraction like hypokinesis, akinesis, or even dyskinesis. And also we can assess any abnormality in myocardial thickening during contraction. Now, what does an MPI image look like? In MPI, the heart is cut into 3 sections along 2 axes. When we cut the heart along the short axis, it looks like donut, and when it is cut along the long axis in the vertical plane, it looks like sideways U. And lastly, when the heart is cut along the long axis in the horizontal plane, it looks like inverted U or horseshoe. And the images are displayed as slices with the stress and the rest images arranged alternatively. These are the planar projections. So the upper set of images is the short axis, the mid portion or mid set of images is the vertical long axis, and the inferiormost portion is the horizontal long axis. This portion, the leftmost or left uppermost part, is the apex, and as we go towards the right, we are going towards the base of the heart. In the case of vertical long axis, the leftmost part is the septum. As we go towards the right, we are going towards the lateral wall. In the case of horizontal long axis, leftmost part is the inferior wall, and as we go towards the right, we are going towards the anterior wall. Now it is obvious here which portion of the heart is showing which part. See, as we can see here, this right part is the lateral wall, upper part is the anterior wall, lower part is the inferior wall, and left part is the septum. This is for short axis. In the case of vertical long axis, this pointed part is the apex, upper part is the anterior wall, lower portion is the inferior wall, and the left part is the base. In the case of horizontal long axis, pointed part is the apex, and this portion on the right is the lateral wall. The opposite side is the septum, and the inferior part is the base. This is how a gated SPECT imaging or image looks like. We see the heart actually pumping here, and with this we can actually calculate or assess any abnormality in the contraction or myocardial thickening. Same here, this is the 3D representation. We are seeing the left ventricle contracting from different angles, and we can find or assess any abnormalities in contraction or myocardial thickening during contraction. Now we come to the polar map and the 3D display. These are a different kind of representation of an MPI image. In the polar map, the left ventricle is opened up like an umbrella, so that the apex lies at the center and the base at the periphery. The left ventricle is opened up like an umbrella, so the apex lies at the center and the base at the periphery. What happens when we open an umbrella? When we open an umbrella, the tip lies at the center and the base of the umbrella lies at the periphery. Similarly, when the left ventricle is opened up like an umbrella, the apex lies at the center and the base at the periphery. So this left part is the septum, the upper part is the anterior wall, right part is the lateral wall, and the lower part is the inferior wall. This is the stress polar map. This is the rest polar map. So as we can see here in this picture, in the stress polar map, there is a dark area here in the anterolateral wall and the apex mainly, even though there is dark, a little bit of dark area in the infralateral wall as well. Now all these areas improved in the rest polar map. That means the color is coming as vibrant as the normal counterpart. So that means that during stress there was stress-induced ischemia or reduced perfusion, which improved in the rest polar map. That means it is called reversible ischemia, and this polar map here is the reversibility polar map, and this much area of bright and the colorful area is the area which is affected by the reversible ischemia. This is a little bit of a detail about the quantification. I will not go much into the details, but simply it is showing that even we can quantify even the myocardial thickness, and we can also quantify the amount of myocardium jeopardized due to the stenosis in terms of surface area of the ventricle, or in terms of percentage of the area affected in a particular arterial territory. And even we can also quantify how much gram of the myocardium has been jeopardized. This is the time activity curve. This is used to assess and calculate ejection fraction and volumes. These are the 3D display, and with color coding we can assess the quantifications I have mentioned earlier, similarly in this 3D display also. So what are we looking for in an MPI image? As I have mentioned earlier, in MPI, stress and the rest images are always compared. So when we find a cold defect like this in the stress image which improved in the rest image, this is called stress-induced ischemia. However, if this defect persists even in the resting images, then that is infarction. In a normal scan, there will be no defect at all in both the stress pictures or stress images and the rest images. Now we come to the interpretation of MPI scans. This is a perfectly normal MPI scan. As we can see, this is the short axis, this is the vertical long axis, and this is the horizontal long axis. As I have mentioned earlier, the stress and the rest images are arranged alternatively. This is the stress, rest, 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 and these are the planar projections. As we can see here, both the sets of images, like the stress and the rest images, look or appear similar in terms of the intensity of the color here, without any defect at all in both the stress and the rest pictures. So this is a normal scan. Now we have another patient. There is a reduced perfusion in the anterior wall, apex, and the infralateral wall. We can also assess from here in the polar map, anterior wall, apex, and infralateral wall. And these defects in the stress images improved in the rest images, as is shown by the arrows here. Defect, improvement. Defect in the stress image, improvement in the rest image. Stress defect, improvement in the rest image. So this is a classic example of stress-induced ischemia or reversible ischemia. In the third patient, we see no uptake at all in the inferior wall, both in the stress and the rest images. both in the stress and the rest images. The inferior wall is actually missing. We can also assess it from the polar maps. In the stress polar map, there is no uptick. Even in the rest polar map also, there is no improvement. So this is a classic example of myocardial infarction. See, in this 3D display, the dark portion in inferior wall is nicely seen. Now we come to the last portion of today's lecture, that is the clinical value of myocardial perfusion imaging. MPI has a very excellent negative predictive value. That means that let's suppose a patient undergoes an MPI scan, and the MPI scan turns out to be normal. Then the risk of the patient of having a cardiac event in the form of MI, myocardial infarction, or cardiac death is less than 1% annually. In fact, MPI serves as a gatekeeper to the cardiac cath lab. When the MPI scans are normal, there is low risk, and the suggested treatment modality is risk factor modification. When the scan is mildly abnormal, there is low risk of cardiac death and intermediate risk of MI, and modality of treatment suggested is aggressive risk factor modification and medical treatment. However, in those patients with moderate to severely abnormal MPI findings, the risk is high. So these patients are ideal candidates for a more invasive mode of treatment in the form of revascularization, which might be PCI or CABG. Diabetes is a problem everywhere, and the heart is no exception. I have mentioned earlier that a normal MPI scan predicts that the annual cardiac event rate is less than 1% in normal population, that is about non-diabetics. However, in diabetics, even a normal MPI scan has a event rate of approximately 2% as compared to less than 1% in the non-diabetics. From this survival plot also we can see normal perfusion in non-diabetics. These patients with normal perfusion and non-diabetic survive better than diabetics, even though these diabetics also have normal perfusion scan. So diabetics need special attention from the management point of view. In asymptomatic diabetic patients, if there is high risk perfusion abnormalities on the MPI scan, then revascularization improves survival as compared to medical therapy alone. Now, asymptomatic diabetic patients, if they do not have any high risk perfusion abnormality on the MPI scan, then there is no incremental value of either of these two modalities of treatment over the other. Now this is a very important bar chart showing the survival benefit of medical treatment versus revascularization when these treatments are based on the findings of the MPI scan. If the MPI scan shows large abnormality or high risk abnormality, and if these patients receive only medical treatment, dark bar here is the medical treatment, and if these patients only receive medical treatment, then the death rate is high, 6.7%. Likewise, if the MPI scan shows subtle or no abnormality, and if these patients undergo revascularization, then still the death rate is very high, 6.3%. This means that uh, 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 people might undergo revascularization based on the angiography findings only. Angiography findings might suggest some stenosis, uh, while myocardial perfusion imaging does not show any abnormality. So, in this subset of patients, when the myocardial perfusion imaging does not show any abnormality or subtle abnormality, if these patients are allowed to undergo revascularization, neglecting the findings on the myocardial perfusion imaging and believing only the angiography findings, that is the anatomical modality, then event rate is high. So the maximum benefit on survival is seen in those patients who have high risk factors, high risk perfusion abnormalities on the MPI scan and who undergo revascularization. So to sum up, high perfusion abnormality, if medical treatment is done, event rate is high. Subtle or no abnormality on the MPI scan, if revascularization is done based on the angiography findings only, event rate is high. High abnormality on the perfusion scan, if revascularization is done, the best benefit on survival is achieved. Now we have a very important issue here, that is the issue of follow-up of patients who have undergone interventions in the form of PCI or CABG. In patients who have undergone PCI and who present with chest pain within 1 month of the PCI, then 30% of them are found to be due to restenosis. In CABG patients, if the follow-up perfusion imaging shows any perfusion defect, then the usual cause is then the usual cause might be graft disease or stenosis beyond the anastomotic site or non-revascularized native artery or even restenosis. CABG patients who have undergone CABG and who present with perfusion abnormalities on the myocardial perfusion imaging scan within 1 year of the CABG, then the usual cause is perianastomotic graft disease. And in those patients who present with any abnormal perfusion defect in the MPI follow-up MPI scan, after 1 year of undergoing the CABG, the usual cause is found to be due to restenosis. So even in the follow-up scans, the higher the abnormality, the higher is the event rate. And it has been suggested that symptomatic patients of CABG who have undergone CABG less than 5 years and all patients, whether symptomatic or not, who have undergone CABG more than 5 years back are ideal candidates for following up with myocardial perfusion imaging regularly. Now, let me talk about a few points on myocardial viability because it is important when intervention in the form of PCI or CABG is planned. There are two major modalities of doing a myocardial viability assessment. The first one is the cardiac FDG PET scan, which is the gold standard. FDG is fluorodeoxyglucose, which is a glucose analog, and the second is thallium. In this, we do the rest study only without the stress part. Now I'll talk about mechanisms. Normally, the heart or the myocardium uses fatty acids for its metabolism as a source of fuel. However, in the presence of ischemia, the oxygen delivery downstream to the stenosis is reduced, and if the myocardium supplied by the stenotic artery is still viable, then it shifts from fatty acid metabolism, that is by beta oxidation, which is an oxidative process, to a more efficient process under reduced oxygen supply, that is anaerobic glycolysis. Since FDG is an analog of glucose, it undergoes the anaerobic glycolysis by the myocytes. In glycolysis, glucose is phosphorylated by hexokinase to glucose 6-phosphate. Similarly, FDG is phosphorylized by hexokinase to fluorodeoxyglucose or 6-phosphate, that is FDG 6-phosphate. However, the further steps for glycolysis cannot use FDG because the hydroxyl group in the second carbon position is important for the enzymatic actions. In FDG, the second position carbon has fluorine instead of hydroxyl group, so the FDG is stuck there inside the myocardium, and we see uptake on the PET scan. That is how a cardiac FDG PET scan works. Now, coming to the thallium viability study, the property of thallium which makes it useful for viability assessment is called redistribution. There is a reduced uptake in the septum and anterior wall as compared to the lateral and infralateral wall here at half an hour after thallium injection. This is the normal portion as shown by the red curve. This is the abnormal or reduced perfusion portion as shown by the white curve here. Initially, due to the stenosis or due to the reduced perfusion, the delivery of thallium is reduced, blunted as compared to the normal steep fast uptake. But as time progresses, thallium, which is present inside the myocytes, redistributes. That means exchanges with the thallium ions which is present outside the myocytes, that is in the circulation. So when we do the imaging, delayed imaging, say here it is 18 hours, the initially photopenic area or initially reduced perfusion improved, or the uptake is normalized as compared to the normal portion. This is how a viable myocardium looks like in thallium rest redistribution study, because we do the test at rest and the redistribution study as delayed rest. We call it redistribution rest redistribution study. This viable myocardium shows uptake which was initially photopenic. If this myocardium were actually scar, then there would not be any improvement. This is how viability assessment is done by thallium. Now, this is a nice illustration of how thallium can be used for predicting myocardial viability. Here it is shown stress, rest, but these are problems due to the input system in the computer. These are all rest images. Actually, these are rest image. This is delayed rest image, or we call it rest redistribution image. So similarly, this is rest image, rest redistribution image. This is rest image. This is rest redistribution image. So initially in the rest image, there is resting hypoperfusion or cold effect in the apex anteroseptal wall and the septum. You can also see from the polar map also apex, anteroseptal wall and the septum. But on the delayed redistribution phase, there is improvement or redistribution in the uptake. The defect in the rest image, improvement in the redistribution phase. Defect in the rest image, improvement in the redistribution phase. So this means that the myocardium, which is jeopardized here in this area will improve if intervention is done in the form of CABG or PCI. This is before intervention. Now this is after CABG. I do not find any abnormality here. The initial defect here improved. Initial defect here improved. So thallium reliably depicted or predicted that the jeopardized myocardium would improve after intervention, and this is the proof. Now this is the viability assessment by FDG PET. I could not get a good image, so please bear with me with this bad images. Perfusion study with PET is done by ammonia, and metabolic study is done by FDG here. So we see here a defect, resting defect, that means resting hypoperfusion in the interseptal wall and the apex. But these corresponding areas show FDG uptake. This is called mismatched perfusion metabolism defect. So more than 80% of these people will improve after revascularization. Now we have another patient who has resting hypoperfusion or no perfusion in the lateral wall and the infralateral wall here, and the FDG PET scan also shows no uptake in the corresponding area. So this is the matched perfusion metabolism defect. Matched perfusion metabolism defect. Matched perfusion metabolism defect. And these patients will not improve even if revascularization is done. This is a very important chart. I have taken it from the Ontario Health Technology Assessment Series 2010. It is an evidence-based analysis of cardiac fat for myocardial viability. So what does this chart show? It is telling us that when a cardiac FDG PET scan is done for myocardial viability and the scan shows viable myocardium, if revascularization is done, then mortality rate is low. That means survival benefit is high. However, if the viability study by PET shows viable myocardium, but medical therapy is done instead of revascularization, then mortality rate is high. So, in short, an FDG PET scan showing viable myocardium warrants revascularization. PET has a very high accuracy in predicting myocardial viability with a reported value of 90% accuracy, sensitivity of 94%, specificity of 95%, and pretty high predictive values. Thank you for your attention, and thank you for viewing this video. And if you are satisfied with this video, or if you are satisfied with my humble and simple step to popularize or uplift nuclear medicine in Northeast India, please hit the like and share button. And thank you so much. Thank you once again.